Recording in progress.
It'll be just a few moments before we begin while we admit people and allow permissions to record. So in just a few moments, we will begin. Okay, I believe all appropriate permissions have been granted. I will turn it over to you, Dr. Vanderhoff.
Well, thank you very much. Good afternoon. I am Dr. Bruce Vanderhoff, Director of the Ohio Department of Health, and I want to thank all of you for joining us again this afternoon. Unfortunately, we're continuing to see our Delta wave drive COVID-19 cases ever higher, with now more than 5,000 new cases reported just yesterday, a high we saw last in January. And that's been on top of many days with numbers in the 3,000s and 4,000s. Those figures are about 10 times the numbers we saw just a month ago. And as we shared yesterday, our cases per 100,000 averaged over 2 weeks now sit at well over 300. And remember, we were all the way down around 17 in early July and at around 50 just 1 month ago. That means we're seeing new cases at a rate similar to what we saw this past January and February. It's important for us to look back and think about how we were living in January and February. And as we think ahead to the future, how important it is for us to take steps to avoid these repeated waves of COVID-19 that place lives at risk and crowd our hospital beds. Now, of real concern is that our hospitals are busier than ever. The Ohio Hospital Association reports that statewide, about 1 in 10 patients in our hospitals are there with COVID-19, and about 1 out of 6 patients in the ICU is battling COVID-19. Somewhat alarmingly to me is that we're seeing younger adults right alongside older age groups. Now, some of that undoubtedly reflects the very good protection afforded by our vaccines to those who are 70 plus and are highly vaccinated. We've been keeping an eye on the trends, and I'm going to share a graph with you right now that I think helps us visualize what's occurring over time. As you can see from the graph, in early July, our hospitalizations and ICU admissions were relatively stable, even decreasing slightly, with the number of patients admitted with COVID-19 hovering in the 200s, varying from 60 to 70 patients in the ICU and about 40 to 50 COVID patients on ventilators. Later in July, we began to see a real increase in hospitalizations. And as August has progressed, this increase has gotten much sharper, moving upward with a very steep incline. Although not quite as dramatic on the chart, we've also been seeing increases in our ICU admissions. And if you pull out a specific day, take July 9th, for example. On that date, we had 200 people in the hospital with COVID across the state. Yesterday, we had more than 2,000. That's 10 times the amount we saw just 7 weeks ago. On July 9th, there were 56 Ohioans in the ICU with COVID, and yesterday, 620. That's an increase of more than 10 times. And on July 9th, we had just 44 Ohioans on ventilators, while yesterday, 365. These are troubling facts. Facts that really have us and our hospitals very concerned. And sadly, it continues to be true that unvaccinated Ohioans are by far and away the COVID-19 patients who are filling our hospital beds. Also, now with Delta, we're seeing people of all ages get sicker quicker and requiring hospital care. Now, vaccinations are clearly our best protection, and by nearly everyone's calculation, they're our best way of ultimately declawing this virus. They're also our safest and most reliable means of alleviating future pressure on Ohio's hospitals. And while we're seeing improvement in our vaccination rates, we certainly don't have enough vaccinated or infection-based immunity yet to have these repeated variant waves under control. That said, we have crossed the 60% vaccination threshold for those 12 and older in Ohio earlier this week, and that is an outstanding and important milestone. It's important to highlight that vaccination rates among those 12 and older, not just vaccination rates for adults, are important, particularly as we continue to reinforce the importance of keeping our children in school for in-person learning as much as possible and protecting everyone eligible for vaccination from this terrible virus. Now, as more Ohioans gain robust immunity through vaccination, what we're doing is reducing the opportunities for this virus to spread, mutate, and inflict serious medical harm. And we get closer to the day when this virus can no longer upend our lives. Today, I'm joined by the physicians who are the hospital zone leads for our state and have helped to guide our regional COVID-19 response in hospitals throughout this pandemic. First, representing the most southern portion of our state is Dr. Rick Lofgren, President and CEO of UC Health. Dr. Lofgren, can you tell me a little more about what hospitals in your zone are seeing at this time?
Thank you, Bruce. I would really just echo what you said about the state in general. We are seeing a decisive surge that started in the middle part of July. When you look at the trajectory about the rate of growth of the number of new cases that are requiring hospitalization, it parallels what we saw in the fall when we had the largest surge. To put in perspective, in the greater Cincinnati area, in the June and into early July, we were seeing about 40 to 50 people hospitalized in our region with COVID-19. Today, we have 363 people hospitalized and 118 of those in the ICUs. So this has been the same dramatic change that we've seen before. And obviously, we are reactivating all the things that we've learned along the way over the last 18 months to prepare for the surge. That one of the things I would say is that the big surge that we saw in December and January in the greater Cincinnati area peaked around 800. That really did stretch our healthcare delivery system. Didn't quite break, but we definitely saw the push. I think what we're seeing now is the same sort of upsurge. We are concerned that we're pleased that we've learned a lot. We know how to are more effective in treating. The supplies that we have from PPE appear to be fine. We actually think we have adequate beds, and we keep track of the ventilators. I can tell you, and you'll hear throughout the state, the issue is that we don't have and concerned about having adequate number of staff to take care of the patients if the surge continues. You know, the big surge last fall and into the winter, you know, the workforce here who were truly heroes rose to the occasion, working overtime and extending themselves and stretching themselves. And since that time, we've unfortunately lost people who are who opted out of the field. Plus, people are just tired, and really the ability to stretch is really taxed at this point in time. The other two things that I would just echo is that we're seeing definitely younger patients. We're seeing people who are hospitalized who are in their 20s and 30s who have no pre-existing medical conditions related to this Delta virus, as well as we're seeing in some pediatric cases as well. The vast majority of people are unvaccinated. We have seen patients hospitalized with what we call breakthrough, meaning that they were vaccinated, but they did acquire it. Most of those people have significant underlying immune deficiencies, which really speaks to the fact that the vast majority of people that are acquiring the disease to the point that they require hospitalization are in fact unvaccinated individuals.
Thank you. Thank you very much, Dr. Lofgren, for that update. Next, we're joined by Dr. Andy Thomas, the Chief Clinical Officer at the Ohio State University Wexner Medical Center. Dr. Thomas, what are you seeing among hospitals in the more central portion of our state?
Thank you for the question, Bruce. I would really echo a lot of what both you and Rick have just shared. We do zone-wide calls with over 40 hospitals and health systems across the 3 regions of the state that are in zone 2. We do those every Monday, Wednesday, and Friday at 9 a.m. And we had cut down to once a week prior. We've had to increase the cadence of those, mainly because we were fielding all sorts of requests and concerns, everything from a hospital that had run out of BiPAP machines, a way to deliver oxygen to patients just short of being on a ventilator, and we needed to get them some supplies. Similar with high flow oxygen, when they had seen a rush of patients over a short period of time. We have one hospital that has taken their emergency preparedness tent out and are seeing their treat and release emergency department patients in a tent because their ER is so full of patients waiting for a bed. We had just today, one of our regional hospitals, it's a 19-bed emergency department. They had 11 patients boarding, waiting for an inpatient bed. Now, the good news is we have 40 hospitals and health systems in the zone. We were able to parcel out 2 or 3 of those patients to each of a number of hospitals that volunteered to take a couple extra. But I can tell you in Central Ohio, the 3 large health systems, Mount Carmel, Ohio State, and Ohio Health, all of us are facing significant capacity challenges. We were busy with non-COVID patients prior to this, partly because people had put off care, partly because, frankly, people are showing up more acute or sicker than they have really ever in the past, I know, for here at Ohio State. So the lengths of stay for some of those patients are longer. But then to add COVID on top of that, your point earlier, Bruce, about 1 in 10 patients in the hospital in Ohio for any reason are there because they have COVID. To think just 30 days ago, it was 1 out of every 38 patients. That crowding out phenomenon in our ICUs going from 1 out of every 24 patients to 1 out of every 6 with COVID. It's going to eventually start to impact the ability of our systems to deliver routine care and have routine clinical operations. In fact, one of our major health systems, and this was in the news yesterday, has decided next week at 4 of their hospitals in the region, they are not going to be able to do elective cases, surgical cases. And we're not talking cosmetic things here. We're talking, medically necessary surgeries. Now they could be delayed or postponed for a couple of weeks, but if those surgeries require an inpatient bed, they're postponing them. That's a pretty major change. And really, to Rick's point earlier, it feels like where we were in mid-December. It feels like where we hear hospitals in Florida have been, say, over the past 4 to 6 weeks, hospitals in other states. So it's quite concerning. Now we have great partnerships. We're all collaborating and working well together. But this is going to be a difficult road if cases don't peak soon and hospitalizations peak soon.
Thank you very much, Dr. Thomas. Finally, I'm joined by Dr. Robert Wiley, Chief Medical Operations Officer at the Cleveland Clinic. Dr. Wiley, what are you seeing and hearing from hospitals in the northern portion of our state?
Thanks, Bruce, and certainly agree with the comments made by my colleagues in Zone 1 and Zone 2 in terms of the overall nature and your comments about the pandemic so far. Fortunately for Zone 1, the infection is coming up from the south. So we originally saw infection in Arkansas, Missouri, and Louisiana, spreading from Texas all the way to Florida, and then coming up north, traveling through Tennessee, Kentucky, and then into southern Illinois, Indiana, and Ohio, and now spreading up to the mid to the northern parts of all of those states. So we have about half the beds and half the both regular nursing floor and ICU beds in Zone 1 in the state. And we're about 75 to 80% occupancy at this point, but it's climbing every day. So this morning we had over 900 patients in the zone. We had nearly 300 in our ICUs. And although our capacity may show 75 or 80%, that was the capacity before we started losing staff. So one of the things that's happened is that we all started losing staff as people started to wither a little bit under the tedium of a year and a half of infection and dealing with these very, very sick patients in the ICU and watching fatalities at a fairly rapid rate compared to our usual number of patients in the hospital. I want to emphasize what Dr. Thomas said in terms of the other patients in the hospital. So we were already full with patients who were severely ill before this recent rise in COVID. And what we think happened is people deferred their care during the pandemic. Maybe they were afraid or reluctant to come to the hospital. Maybe they put off routine checks. And so illnesses, including cardiac disease, neurologic disease, et cetera, cancer, were caught a little later and is driving them to come into the hospital more often. That, coupled with this bulge in COVID patients, is really stressing the system a little bit. In terms of what we're looking at, as best we can tell, we had a peak before in the wintertime of about 5,100 patients in Ohio. We are hoping this peaks out about 3,000, but that's only a guess, as our models are only a guess of what's going to happen. It could be more than that, like Florida, which is actually a little bit more vaccinated than Ohio. We have 5 hospitals actually in Florida with nearly 1,000 beds. They are all under severe strain right now. So we're very attuned to what might happen. We would like everybody to do whatever they can to get vaccinated, but also follow the routine things that we've been talking about before. That's wear a mask, try to keep socially distant, and protect our kids in school by getting vaccinated so we prevent transmission not only from parents to kids, but if kids do become infected, back to parents again so that they're in our hospital. So I'll turn it back to you, Bruce.
Well, thank you again, Dr. Wiley. Well, I think it's clear from what my colleagues have shared that our hospitalizations today are at levels that are quite concerning, and they're increasing at a troubling rate. Now, we need to all do our very best to prevent the spread of COVID-19, in part to allow our hospitals to be in a good position to continue to provide the necessary care that so many Ohioans need. And that includes a variety of other diagnoses beyond COVID, things like stroke or dealing with car accidents, cancer care, and more. Now, given how busy our hospitals are, I want to make sure that people understand that we have quite a bit of COVID-19 testing capabilities beyond what's available through our hospitals. So if your symptoms of COVID-19 are of a mild to moderate nature, and you're really looking to confirm your diagnosis rather than seeking medical advice, testing is available statewide outside our hospitals and emergency rooms. In addition to being able to get a test at many of our pharmacies or other non-hospital providers, we've also partnered with many libraries and local health departments where you can pick up a free rapid test known as Binax Now, which is proctored remotely from the comfort of your home. So you're not having to do that test without some guidance and support. Keep in mind, demand for testing is high, so please call ahead to make sure a test is available wherever you're going to get tested. Now, COVID-19 hospitalizations are also largely occurring among the unvaccinated. And we as Ohioans can really help relieve the pressure on our hospitals, especially over the long term, by choosing to be vaccinated. COVID-19 vaccines remain our very best protection and our best way out of this pandemic. So if you haven't been vaccinated yet, please talk to your doctor or other trusted health professional to get the facts. And now I think we can take questions. Alicia?
Yes, thank you, Dr. Vanderhoff. Our first question today is from Andy Chow with Ohio Public Radio and Television.
Hi, everyone.
Hi.
This question, Dr. Vanderhoff, this is for you. And you just mentioned this, there's a wide availability of these at-home tests now where people can get it, find out if they test positive or not. I was wondering if, when we see these daily case numbers, those are case numbers that are reported into local health departments. Do you think that's an accurate reflection of just how many cases there are in Ohio, given that somebody might just take an at-home test positive, and then just stay home without reporting that case anywhere?
Yeah, actually I do. And it's a wonderful question, Andy. Thank you for asking it. These tests that we now have available that early in the pandemic were a technology and a capability that we simply didn't have the way we do now, are ones that allow us to capture those results very reliably. As I mentioned, these are proctored tests. So in order for the test to be completed, people are working online with a professional who then is able to help us assure that those results get recorded. So more of our continued effort to take advantage of convenience and technology to assure that testing is completed in a timely way and in an accessible way.
Thank you, Dr. Vanderhoff. Our next question comes from Jim Provance with The Blade.
Hello. I appreciate your taking our questions again, and this is for you, Dr. Vanderhoff, as well as your colleagues. You've been holding these briefings 1 or 2 times a week, and yet the numbers are still getting worse. Personally, as a doctor, how do you usually react when a patient refuses to take your advice?
Well, that's also a very good question. And I think my colleagues all have had similar experiences in terms of how we help people along the journey of understanding either their illness or understanding the situation that they face. And knowledge really is power. And the way that I've really viewed our efforts has been to help the people of Ohio understand exactly what's happening, to understand the accurate information about the testing and treatment that is available, and especially about the importance of how they can keep themselves and their families safe, particularly through the power of our vaccines. Now, of course, as doctors, we always want our patients to hear the message that we're sharing and take the steps that we think are in their best interests. But we also understand that in order for people to accept our treatment recommendations, we have to be patient. We have to continue to work with them to understand the information and why we are encouraging them in a particular direction. Let me turn to my colleagues. Anything that, maybe I'll start up north with Dr. Wiley, in part because he's also pediatrically trained and it might be able to offer some of the perspective that also extends to our younger Ohioans who might be considering vaccination.
Thanks, Dr. Vanderhoff. Glad to take that one on, because when you work within families and you're a pediatrician, you actually have 2 patients. You've got the actual patient sitting in front of you who could be a year or 2 old, or 17 or 18 or 19, and you usually have 1 or 2 parents in addition. I think it involves an honest conversation about what the concerns are with the parents as well as the patient. And there are many concerns out there. There's a lot of misinformation. You can't really just be shrugged off and saying that's inaccurate. You really have to understand, you have to listen, And then you have to explain the relative risks of being vaccinated versus not vaccinated, and what the chances are of getting sick with COVID are, and what it means to be sick with COVID, not only in the acute phase, but also with the 25% or so of patients who develop symptoms that last over the long term that have to be managed. And I think as you explain this and have conversation and take the time, that's when I think you can start to make a difference in terms of the perceptions.
Bruce, I would add to Bob's comment. I use the same approach that I would take if I was doing smoking cessation counseling or talking to someone about weight loss or other lifestyle changes. And the concept is you meet the patient where they're at. I find that most friends, most family members, most patients that I talk to, frankly, are just trying to put the information in context. They hear a lot of information. Actually, one of the benefits, I think, of how most media have covered this is they're putting out a lot of good, positive, helpful, true, transparent information. That's great that our FDA and our CDC put out that information transparently. But if you don't have it in the proper context, that can be a problem. I had a similar conversation with one of our staff here at the medical center who had not been vaccinated, someone I've known for well over 2 decades. And frankly, she was just scared, pulled me aside in the hallway and said, will you talk to me for a couple of minutes about this? And she had big concerns about myocarditis with the mRNA vaccine. So it came out a few weeks ago that there is a risk of myocarditis or inflammation of the heart muscle after getting the mRNA vaccine. It's a risk of 1 in 50,000 patients. Tends to be mild, tends to go away on its own, doesn't cause any severe issues. But you have to realize that 1 in 50,000 sounds like it's high risk. But if you realize the virus itself, the risk is closer to 1 in 50 or higher. It's 1,000-fold more risky to let yourself get the virus than it is to get the vaccine. Plus, if you get the vaccine and are protected from getting the virus, to Bob's point, all those other side effects, brain fog, fatigue, missing 2 weeks of work, whatever it might be, don't happen either. So once you put that in context, a lot of people say, oh, well, that makes a lot of sense. There are people out there spreading disinformation that's frankly disrespectful to our communities, that the vaccine magnetizes you, there's a chip in it, all those things. I don't even, frankly, worry too much about trying to convince those folks otherwise. But it's really these people in the middle that have real questions. You meet them where they're at, you treat them with respect, don't be judgmental. And most of them, it's nice. I get a picture the next day or 2 days later with a copy of a vaccine card saying, thanks so much, Andy.
No,
Thank you. And Rick, anything you'd add?
Yeah, I'd add, one of the things is that the Latin origin of the word doctor actually means to teach. So that it is about informing your patients. And a couple of things that both Bob and Andy talked about is you need to personalize it. These are raw statistics. How does it affect me? You got to get into understanding the choices, as Andy so eloquently said, and understand the trade-offs, which is not necessarily intuitive. And you really have to discover what are the latent anxieties. And those are the core of any sort of role that a physician plays, is that key role is actually to teach and to understand where they're at, what their latent concerns are, what their choices are, and what that means in terms of trade-offs.
Thank you, Dr. Lofgren. Our next question comes from Titus Wu with the Columbus Dispatch.
Hi. During this press run, a lot of you mentioned about kind of these staffing shortages playing kind of a major role and you guys fearing kind of a new COVID-19 wave. One, I was wondering, I'm not sure if any of you had numbers or anything, but how on average, short-staffed is an Ohio hospital? And two, I was curious if any of the recent, vaccine mandates that, a lot of these hospitals have, recently put in, if that accelerated kind of the loss of staff.
So thank you for that question. I'm going to turn maybe to Dr. Thomas to kick us off.
Sure, I can comment on that. I think that the staffing issues that we're seeing started long before anyone announced any vaccine requirements. We've been hearing about this really since the mid-spring from a lot of our hospitals. It could be early retirements. It could be just people that are frankly burned out, and we've been having them work overtime by their choice, and now they're choosing to not do that. And it's not just nurses either. It's respiratory therapists, it's radiology technicians. It's really across the board. The toll that this has weighed on people with over the last 18 months is kind of incalculable in a way. I give the folks at the front line in all of our facilities just an immense amount of respect for what they've done and persevered through. So we, frankly, I believe all hospitals that I know of, at least in my zone, that have put in a vaccine requirement also have exemptions in place for medical issues, religious issues, or certainly many even have for just kind of personally held beliefs. So I'm not aware of at least anyone at my organization yet who has quit their job because of this. It's really more, we don't have the elasticity of extra people and extra hours to expand our beds further as we hear about these numbers of increased hospitalizations. But these trends started long before vaccine requirements have come up over the past few weeks.
I'll just add to that what Andy said is that, even before COVID, we were faced with chronic shortages of healthcare personnel, particularly nursing. The nursing has just risen to the occasion, but people have left the field. I can tell you that early in the greater Cincinnati area, I think there were like 1,600 nursing positions posted before this onslaught of surge and concerned about even the vaccines. I think it also what applies to is respiratory therapists. One of the things we've relied on in the past with this chronic shortage is says the nurses and others stepping up and taking extra shifts and working overtime and stretching themselves. And I can tell you that workforce is just tired.
Over 20,000 people in Ohio, and considering the mortality and some of the people being younger now, and then we had to restrict visitation to try to keep other caregivers as well as other patients in the hospital safe. So people going through that experience of taking somebody through a terminal event without a lot of family support, and they're the ones providing almost all the support or sometimes all the support in an ICU, is difficult on individuals. And I think everybody did what they could. But as the pandemic stretched out, and particularly in this new wave, so we got to a place where we were pretty excited during the early part of the summer. The rates were pretty low. There weren't many people in the hospital. We took a breather just like everybody else did and thought maybe we're over this. But Delta hit in the United States in March. It became predominant a few months later, and then it's taken off in the United States. So I think what we're seeing is a reaction to this is coming again. It's very difficult to manage. It takes a lot of interpersonal skills and draws a lot out of people who are on the front lines. So I think that's part of it that we're seeing, in addition to being short-staffed before this pandemic ever started, like the others have said.
Thank you all very much. Our next question is from Anna Huntsman with IdeaStream.
Hi there. Thanks everyone for doing this call. My question is specifically for Dr. Wiley because, we're here in the Cleveland area. So I kind of wanted to, you were talking about there's capacity, but these staffing shortages. It sounds to me like I just want to know more about if you could speak to, are any of the hospitals needing to postpone elective surgeries? Is that something that we could see in the future? Are you lacking equipment? And kind of the second part of this is, do you feel like the northern region will follow suit of what Columbus hospitals are experiencing right now in that regard?
So I'll answer the second part first. So we have plenty of protective equipment. We have plenty of ventilators. Those have accumulated, over the last year and a half. We were short in the beginning, but I think all of us have plenty of that equipment now. In terms of looking at what's going to happen, it's been very difficult to predict throughout this pandemic. So we've seen 4 or 5 surges, depending on how you look at it. I'm not sure we have a good handle on how the virus acts. We see a rapid upswing, a plateau, and then a rapid drop. And we've seen this 4 or 5 times. The biggest and longest surge of about 6 months occurring in the winter time, November, December, January, February, March. The 2 other ones lasting about 90 days apiece. The biggest surge lasting about 180 days. We can't really explain any of it about why it started and why it went away. So we'll have to see what this means. Certainly, as I mentioned, in the southern states, it's already plateaued. It's actually dropping a little bit. in the states most affected in the South. So hopefully it'll start to drop here. If it doesn't, I think we have enough staff right now. We also load balance, and I can't tell you how important that is among the hospitals in the zones. So if one hospital is full, we will shift patients to another hospital. We'll transfer people up from Columbiana County up to the Akron area, and from Akron to Cleveland, from Toledo to Cleveland, from Youngstown to Cleveland or Akron, just depending on where we need to load balance so that no individual hospital gets overwhelmed. And then in between zones, and Andy and I did this in the last couple days, was we started saying, can you take it? Can we take it? What's the best place for these patients to be hospitalized for the intensive therapy they sometimes need? So we talk frequently in terms of load balancing, and that's a big part of what we've done within the zone. So I think we're okay. We're going to keep our fingers crossed that we don't end up like some of the states in the South. I think if we got to the place, and right now nobody's deferring any cases in Zone 1.
So this is Bruce Vanderhoff. One of the things I would add is to just highlight how advantaged Ohio is by the dialogue that occurs on a routine basis between hospitals all across the state, as well as the coordination and infrastructure that is built into our regional and zone structures. They really do allow us on a day-to-day basis to have our hospitals working collaboratively for the good of our patients and the good of the people of the state to assure that our beds are being utilized in the most effective and efficient way. And it's a real asset that Ohio has that many other states lack.
Thank you very much, Dr. Vanderhoff and Dr. Wiley. Our next question is from Laura Hancock with Cleveland.com.
I was wondering, we're seeing reports out of Texas where they're having to train to nearby states because the and I'm wondering, in particular, in Southern Ohio, are we from maybe like Kentucky or other places, Indiana, are saying we're overwhelmed, we need Ohio to help us? And at what point does Ohio take some capacity for our own people?
Yeah, you were cutting in and out, so I think I understood the question, and I'll answer accordingly. But so when we're looking at the issue of how do we effectively within the state manage this kind of wave of COVID hospitalizations, a lot of how we do that very effectively is what I described just a few minutes ago. We have a very robust regional and zone-based structure that allows for hospital leaders across the state to be in regular dialogue with one another and to be thinking about the needs of our patients and assuring that that patient care occurs. It's actually one of the most robust structures of its kind in the nation. So that's something that happens behind the scenes that I think we can all be very, very proud of. And these three doctors play a very, very important role within their zones of the state in helping to assure that that infrastructure functions in a very effective manner. As far as the relationship with other states is concerned, we are in regular dialogue with at least I'm involved in regular dialogue with the health leaders of the other states. And we have been talking about their needs and their challenges. The challenges, for the most part, that I've heard really relate to this staffing challenge as opposed to physical beds or equipment needs. And they are significant and challenging issues. And there have been, I know, times where patients have been admitted across the lines of our states, and our hospitals have been historically, even before COVID, very good about receiving patients from other states who are in need of care. But in terms of some of the specifics around that, I'll defer to these three physicians who are much more aware of the day-to-day events related to that kind of transfer.
Yeah, Bruce, I'll start. It was 2 weeks ago today when I got my first call from an emergency management person in Texas. The four of us on this call all spoke that day, and pretty much they wanted to fly individual patients here in fixed wing airplanes because they were out of beds and had used up all of the capacity in their adjoining states, Louisiana, Oklahoma, et cetera. And unfortunately, we knew this train was coming down the tracks and made the decision to not engage in that discussion to transfer patients from Texas here. I think others on the call have gotten calls from other states as well. I can tell you at Ohio State, starting about a little over a week ago, we've stopped taking transfers from out of state unless the patient is an Ohio resident or an established patient of the medical center here at our James Cancer Hospital or a transplant patient, et cetera. If they're an Ohio resident, we'll take them from anywhere. But unfortunately, we get a lot of referrals from hospitals in West Virginia and Kentucky. And we've had to ask those doctors to call the hospitals in their state because we feel we have a commitment to those hospitals, those providers, and certainly most of all those patients in those communities in our zone that are going to need that hospital capacity that's in short supply here in Central Ohio. So it's a very, very difficult decision to make, but one that we feel we had to make at this time.
I might add is, in your question was actually in Southern Ohio in particular. I'm going to echo what Dr. Vanderhoff said, is that the fact that the state took the initiative to divide it into the 3 zones and make sure that there's ongoing collaboration between the facilities has been outstanding, and really even the collaboration across the entire healthcare system, including congregate living and nursing homes and public health. And it is unique, and I think it has served us extremely well so that we actually can optimize the resources and provide the best care to Ohioans. Being in Southwest Ohio, of course, we also do collaboration with the tri-state, meaning in our immediate area of Kentucky and Indiana, and make sure that we're working as a region as well as through the state. But just anecdotally to follow up what Andy said, really you do hear what's happening in the southern states of Louisiana, Alabama, Texas, who are truly just overwhelmed. We're extremely busy, but we just recently got a phone call from a request to transfer a patient from Alabama with requiring emergency surgery on their aorta because they couldn't find anybody from there to actually take the patient. And frankly, we are at capacity that we weren't able to accommodate it. So, these are the things that we're trying to avoid.
So it's a reason to get vaccinated again, is to try to reduce this load and this burden we're talking about. In terms of the Cleveland Clinic, we sent doctors and nurses to New York and to Detroit when they were overwhelmed early on in the pandemic. We are very cognizant of the needs of the patients we care for in Ohio. We certainly, if we can provide service that nobody else can or typically provide, like somebody who's had COVID and needs a lung transplant and they've recovered from their COVID, because we're the highest volume transplant center in the United States, we'll try to make special accommodations for those. But we're all trying to manage in terms of what we're doing now. So we'll do what we can. We try to help out. We give consultation. We do telemedicine visits with people in terms of trying to help them in their ICUs. And we'll help whatever way we can. But we're all Ohio based. And certainly cooperation. And we know we have to load balance within the state so that we can treat everybody who needs to be treated within the state of Ohio.
Thank you, doctors. Our next question comes from Jess Hardin with Mahoning Madison.
Hi, thanks for taking our questions today. My question is for Dr. Vanderhoff or anyone who wants to weigh in on this. Senate Bill 22 limits Governor DeWine from reissuing a health order until 60 days after the previous one was terminated or expired. And he terminated Ohio's state of emergency on June 18th. 60 days after that is August 17th. And given this Delta surge that is approaching the crisis seen this winter, the worst of the emergency so far, would you recommend such an order to Governor DeWine?
Well, I think that my role is to provide good medical guidance and medical advice, to share information, not just with the governor, but with the legislature. And we work very hard to do that. The bottom line for all of us as Ohioans, though, is that regardless of whether there's an order or no order, the steps that we need to take to beat this pandemic are very clear, and ones that ultimately rest with us. They're ultimately decisions that require us to take a personal action and accept personal stake in what's happening. You've heard us talk now repeatedly in today's press conference, as I have in other press conferences, about the importance of vaccination. Vaccination is clearly making a difference. If we just reflect on the fact that I shared, that nearly all of our hospitalizations are occurring among the unvaccinated, it really provides a very clear illustration of the truth of what we as physicians have been speaking to in terms of the importance of every Ohioan considering getting a vaccine. And for those who can't be vaccinated, or when we are entering into environments where the risk of spread of the virus may be very high, layering on those other protective measures that served us well in our previous surges, masking, distancing, being mindful of hand hygiene and ventilation, all become very important and are personal decisions and responsibilities. So, at the end of the day, I think that we can get a little distracted by wondering about, a piece of legislation or a particular governmental action from what is really most fundamental. And that is that each of us as Ohioans has to think about our role in addressing this pandemic and take the steps that are available to us to keep our friends, our families, ourselves, our coworkers safe, and to get this thing behind us.
I understand that the message remains the same regardless of whether or not there is an order, but that doesn't appear to be working.
Well, actually, I think that we're making real progress. If you look across the world, the Delta variant has had a huge impact on various different countries. And the one differentiator that really seems to separate those communities at greatest risk from those communities at lesser risk is rate of vaccination. And as I shared before, we're making progress on vaccines. Now, would I like to see higher vaccination levels? Of course. And we're going to continue to work as medical professionals and as the state of Ohio to help get those vaccine rates higher and higher. But clearly, what makes the most difference to a population, whether it is a country or a state or a county, is what the vaccination level is. And places with high vaccine levels do much better than places that have low vaccine levels. So that really needs to be our focus.
Thank you, Dr. Vanderhoff. Our final question today comes from Pete Grieve with Spectrum News.
Hello, good afternoon. I was hoping to ask about monoclonal antibody treatments because we're seeing reports in the South that there's growing demand. Curious if that's the case in Ohio as well. And then also if you could just share which drugs specifically or drugs are being used.
I can certainly begin that and say that yes, monoclonal antibody therapy does remain an important component of the treatment that is available for patients diagnosed with COVID-19, and our physicians and hospitals here in the state are in fact utilizing it to an increasing degree. We have very good supplies of the monoclonal antibodies available here in Ohio and are constantly monitoring to ensure that that supply remains adequate to serve the needs of the patients. I'll turn to my colleagues who are at some of the medical centers that are actually providing these treatments to speak a little bit more to the current available therapies. Maybe I'll start up north with Dr. Wiley, and then we can kind of move through Drs. Thomas's and Lofgren. Dr. Wiley?
Certainly, we're using more monoclonal antibodies than we have in the past. Not only after patients start to get sick before they have much oxygen requirement, but also as a preventive measure for those who are more likely to get sick if they've been exposed. And we see more and more physicians becoming aware of the therapies, and we've actually increased the number of days of infusion. And we do it at Marymount Hospital as a central place within the Cleveland Clinic, as the other hospital systems are also using it throughout Zone 1. I know Andy has had a lot of experience with it.
Thanks, Bob. We use at Ohio State, we use the Regeneron product. That was one of your questions. We were actually part of the clinical trials for the Eli Lilly product initially as well. So we've been involved even when it was in the study phase. We reopened our infusion center 2 weeks ago. We did more in the first 2 weeks of August than we had done in the previous 4 months because the numbers had gotten so low of individuals that needed the infusion. So it's been a great effort. We're now infusing 7 days a week. We infuse at a center at OSU East Hospital in our ambulatory care center. It's a great collaborative effort between our physicians, our pharmacists, our nursing staff. The one thing I will say that's new over this past 2 weeks is providers, physicians will identify their patients who are at high risk. We have a consult process that goes through one of our pulmonologists, and the pharmacists get on the phone and call the patient. We're now seeing some unvaccinated patients turning down the monoclonal antibody treatment because they basically are saying, I didn't want to get vaccinated. I don't want any of this either. And when you think about short-sighted decisions, this is a medication that if you're high risk for admission to the hospital for severe disease from COVID, it can reduce your risk of admission by 70%. And people are turning down that treatment because I don't really understand why. Anything that we can do to make sure people understand, if your doctor tells you that this is beneficial for you to keep you out of the hospital, it is worthwhile doing. It's a simple single infusion. It takes an hour or less. To Bob's point, we are working with some local nursing facilities on post-exposure prophylaxis. We don't have the capacity to do that internally in our medical center right now, but we're working with some local nursing facilities to stand up protocols. We're also working with the Ohio Department of Rehabilitation and Corrections, both for monoclonal infusions for positive patients as well as for post-exposure prophylaxis. Rick?
Yeah, I would just echo what both Drs. Wiley and Thomas said, and that we have seen a real uptick in the use of the monoclonal antibody. But I think the real concern actually along there is we're not using it enough. And getting back to the story that Andy said is that, given the upsurge that we really are encouraging people that come who are eligible, who would really make a difference, that they really do get it. So we're spending some time and effort trying to make sure that we're reaching physicians and practitioners to really people understand this 70% reduction is very effective therapy. Bruce, the one thing I did want to come back to, you talking about with the surge and what can we as a community do. Obviously, what we can do to get this pandemic behind us is really get our vaccination rates up. But I would want to make sure we echo the fact that here and now, with the surge in place, what anybody can do is actually take those simple measures we know that work. And that's returning to wearing a mask indoors. It actually applies if you're vaccinated or not vaccinated, since we've seen some breakthrough infections in vaccinated. They do better, but they still are concerned about the risk. And so I do want to say, vaccines are the way to go. That will make a huge difference. There is a delay in time. This is a here and now problem. Our emergency rooms are crowded. We're pushing the envelope. And really one of the things that is very simple is to return back to those things that we know that work. Stay, the social distancing, wearing a simple mask in indoor events really can make a big difference in helping our workforce today.
Yeah, Bruce, if I could add to Rick's comment about face masking, I think when you look at the rural areas of Zone 2, which are regions 7 and 8, we talked about 1 in 10 patients in the hospital for any reason have COVID, 1 in 6 in the ICU. In the rural areas of Zone 2, 1 out of every 3 patients in an ICU in those areas have COVID, and 1 out of every 2 patients on the ventilator have COVID. So I think specifically those are areas that at different times have been very much spared from the pandemic. That's not the case now. We're seeing the same upward trends in COVID cases, COVID hospitalizations, ICU stays in the rural parts of our zone. And I think when we think about K through 12 schools going back and the gasoline that could add to the fire of this increase in cases, I think getting more schools to understand we already saw our first school district close for a couple of weeks down in Southern Ohio this week because of the increase in cases just a week or two into school starting. So I think that for parents out there, I'm not the pediatrician here, Bob can comment, but for parents out there, I know I send my 13-year-old to school every day, and luckily his school has adopted full masking K through 12. But I think that's the only safe way to keep your child safe in this environment with the Delta variant.
Thank you, doctors. That was our final question for the day. Dr. Vanderhoff, I'll turn it over to you if you have any closing remarks you'd like to share.
Thank you, Alicia. I just want to close by again thanking my three colleagues for taking time out of their schedules to help us share this message, and to all of you from the media for taking your time to hear these important messages and to help us share them more broadly across the state. Thank you.